Okay, so thank you very much for those who have joined here the lecture of immunotherapy and targeted therapy and some more interesting advances to treat melanoma. Okay, so let's start with what is melanoma. So melanoma is a cancer that is originated in with the melanocytes. Most of the melanomas grow in the skin, where the skin is exposed to the sunlight. It is only 4% of skin cancers. Most of the skin cancers are squamous cell carcinoma and basal cell carcinoma and some other cancers, but it is responsible to about 80% of the death due to cancer, skin cancers. So it's a very lethal disease of the skin. It attacks a variety of ages, but the peak is about 60 or 70 years, something like that. But we do see some young patients here, unfortunately, 20, 25, 30, 35. We see them a lot in the clinic here. In Israel, we treat about 1,800 new patients every year. Most of the patients are being treated here in Sheba Medical Center. So if you look on the right, you see that the melanoma attacks different areas of the body according to the sex. So in men, we will expect to see the melanoma growing on the head and neck area, on the trunk, on the back, on the chest. And with the female, we'll see that the melanoma grows essentially on the trunk, but mainly on the legs. So different sites, different areas according to the sex, but it's not only the skin melanoma. Sorry, just a second. Yeah. So it's not only skin melanoma. Melanoma can grow under the fingernails. They can grow in the palms of the hands and on the feet. It's called acral melanoma. It has a different prognosis and it responds differently to immunotherapy and targeted therapy. We'll talk about mucosal melanoma, which responds, unfortunately, in about 1/3. We see the responses to cancer treatments. They are mainly diagnosed, unfortunately, with a higher stage, higher Breslow indexes, and with the diagnosis, in some cases, many cases, we see already metastases to the lymph nodes and to other organs at diagnosis. Eye melanoma is completely different. Usually it does not respond to immunotherapy. It's a really an unmet need, really an orphan disease with very few options to offer, unless we talk about trials. They are included in most of our trials, and we try to help those patients who really otherwise have no other options. So when you diagnose a melanoma, a new melanoma of the skin, usually it starts with a surgery. After a primary removal of the cancer, we have to expand the excision to get some clear margins. If it's on the back, like on the right, it's very simple. On the stomach, it's really simple. You just do a primary closure, but sometimes the location is very complicated, and the decision on the surgery should be taken together with a plastic surgeon, the general surgeon, the ENT doctor, sometimes a gynecologist or an orthopedic surgeon, and to be very creative on how to really operate. So most of our melanoma patients are being treated in a multidisciplinary. They're presented, they come to a meeting where all those doctors are present. We look at the patient and we decide on the spot how to do the surgery and when to do the surgery. And really, sometimes you have to put a skin graft and it's not suitable for all patients. So the dialogue with the oncologist should be very fertile and very important. Some patients are diagnosed with a deeper melanoma of the skin and really necessitates an intervention to look at the sentinel lymph node. What's going on in the lymph nodes? This changes the surgery. It's a little bit more complicated surgery because it happens in a general anesthesia. You have to inject a tracer in order to identify the exact location of the lymph node. You have to inject also another a blue dye, it's called, another tracer that helps to really identify the node, the important node. Here, the connection with the surgeon and the pathologist and the oncologist obviously should be very, very tight. Sometimes the surgeon does not find the sentinel nodes, or sometimes they find the uptake is in more than one station. The interface and the connection between those colleagues should be very, very tight and very important. So this is the sentinel lymph node biopsy. And once the disease is cured, we follow up the patients, but sometimes the disease is diagnosed in a very advanced stage, or sometimes it just comes back after a short period of dormant years, and then you have a metastatic disease. It's a stage 4 disease. It can be very slow, but it also can be very, very quick with a rapid dissemination in the body. It likes to go everywhere, including the brain. 25% of the patients have brain metastases at presentation or during the course of the disease. It goes to the liver and lungs, like other diseases, but also to the muscles, the subcutaneous tissue, and even the epidermis itself, like you see on the leg here. So it's complicated at presentation. The symptoms are complicated, and the cure was recently very complicated. Now it's a little bit more simple because we have the targeted therapy and the immunotherapy. Targeted therapy is a personalized medicine. We try to fit the drug to the patient to see if the patient harbors a certain mutation. In melanoma, it's the BRAF mutation. And if he does have the mutation, then we start with, we have 3 types today of BRAF and MEK inhibitors. And those are promising medications that show a very long-term efficacy. Not in all of the patients, unfortunately, but in some patients, some do really gain benefit for a long time. Immunotherapy, it's a super personalized medicine because what you do here is that you convince the immune system itself to attack the cancer. You don't touch the cancer, don't give a medication to treat the cancer itself. You just give a medication that helps the immune system to attack, to do its job, to attack better the cancer cells. So this comes with a price, obviously, of adverse events, and then we talk about it further down the road. So when you talk about targeted therapy, this is the BRAF gene, as you can see on the left. The normal BRAF it has a V in a codon placed in the 600 place. But the most frequent mutation is a replacement from V to E. It's a V600E, and it happens at about 50 to 60% of the patients. So half of the patients have a mutation in the BRAF. We usually do not start treatment if you don't know the status of the mutation. And we do see some tourists here. We almost never rely on the results of the testing. We repeat the testing here. We do it with the next generation sequencing, and we achieve the response. If the patient has a mutation, we consider starting with targeted therapy, but some patients do gain more benefit if we start with immunotherapy as a first line. And this is just a big picture to illustrate the interaction between the T cells, I mean the immune system, and the cancer cell. So the first line therapeutic options can be targeted therapy and immunotherapy. With targeted therapy, we achieve a very, very important and nice prolongation of the survival. The median survival is at 2 years, and the 5-year survival rate is about 34%. So more than a third of the patients are alive today, thanks to targeted therapy. And as I told you in the beginning of the lecture, the median survival was about 6 to 12 months only. So it's a very important prolongation of survival. It's not perfect, but it's something. What about immunotherapy? Well, here we talk about much higher numbers. There's a follow-up of 6.5 years today, and we see that the median survival is about 6.5 years. I'm talking about years and not months. This is a very impressive thing. It's still a debate who will be the patients to gain more benefit with from immunotherapy as a single agent and not a combination, and who are those who really gain benefit, long-term benefit, if you start with targeted therapy. It's a question, it's a debate, and we have collected some information, some of our experience, and we have published it recently. It's a real-world outcomes of ipilimumab and nivolumab. It's a combination of immunotherapy in patients with metastatic melanoma. We have published info on more than 160 patients treated here in Sheba Medical Center. We saw that if you look at all the population, the response rate was about 50%. So 50% of the patients had their tumor reduced in size. And if you look at the first line, we see that a 61% of the patients had a response, when more than half of the patients had a complete response, or a complete remission of the disease. I'm talking about stage 4 melanoma. This is impressive. A complete response, it's complete remission of the disease. This is something we see in the literature, and we see also here in Sheba. And when you look at the patients who have achieved this complete response, we see that if we follow up 1, 2, or even 3 years on these patients, after those patients, even 5 years here, we see that a minority of those patients have progressed. Most of the patients remained without evidence of disease, and most of them are not being treated at all because they don't need the immunotherapy anymore, because the immune system has studied and doesn't need the immunotherapy anymore. It knows how to attack those cells. The adverse events, so when you take an immune tolerant immune system who is allergic to the tumor and you spill immunotherapy, you may get an immune overactivation. So it's like a monster that feeds from immunotherapy, and it's very complicated to deal with those patients. Essentially, all systems are in the possibility of being hurt. And there is a variety of immune-related adverse events. It can be endocrine adverse events, who are sometimes complicated to treat, like hypophysitis, thyroiditis, adrenal insufficiency, enterocolitis, dermatitis, and even a variety of other immune-related adverse events. So here the interaction with the endocrinologist, the gastroenterologist, the dermatologist, the pulmonologist, the neurologist, rheumatologist, and actually many doctors really engage together and help the patients. We usually consult, we have a multidisciplinary meetings, many of them, and we consult each other on what is the correct approach, not with this disease, but for this specific patients, according to the chronic medications that he takes, the medical history, the response to the initial treatment that we do with steroids or other immune suppressants. Okay, so at a certain point, sometimes the disease is very advanced or advances, progresses despite the standard of care treatment with immunotherapy or with targeted therapy. And then really it comes the questions of then what? What do we do? The standard treatments are mostly not very helpful, and we have to really know the material and be creative with certain types of options, mainly research options. So I will show you a little bit about the things that we do here in Sheba Medical Center, and how we think of out of the box. So I'll talk about the TIL therapy, the microbiome, the immuno-apheresis, and a little bit about intralesional injections. So the local approach is the intralesional injections. There are some options today. There are the oncolytic viruses. The TVEC has proven itself, and it is also FDA approved. It's a herpes virus. But not only this virus, we have several clinical trials here open at Sheba with other types of viruses. Sometimes they are given intralesional, and sometimes they're given intravenously together with intralesionals. Some trials or off-trials options are intralesional immunotherapy. There's the good old IL-2, interleukin-2, which was in the 80s was given IV and has caused serious adverse events. And today it is given intralesionally. There are also the TLR agonists, the stings agonists, and other investigational agents. Very interesting and promising approach. This is one of my patients who has a metastatic melanoma. He had multiple in-transit nodules. You see the picture on the left here with the arrows. These are the nodules. He was treated with immunotherapy as a standard first line. And all he achieved was disease stabilization. So disease was stable, and he even slowly progressed during those 6 months of treatments. So nothing really happened except from progression. You see under the picture, you see the PET CT with all these enhancements of contrast. So these are all disease sites. I decided to continue with immunotherapy, but to give the patients 4 injections of immunotherapy intralesionally. And what we see here that the patient achieved a complete response in all of the nodules. Most of them were not injected. So I provoked a response, an immune response, also in areas that were not injected. This is because I changed the way the immune system responds to the cancer itself. It was in 2019, and today the patient has no nodules at all. He's continuing with immunotherapy because I think it does help. And he unfortunately developed vitiligo, which is a marker for us that the disease is really responding very well, and that the immune system attacks not only the melanoma, but also the melanocytes, which is a nice marker for disease response. So this is what I have to talk about, talking about intralesional therapy. I will talk a little bit about the TIL project. What are the TILs? The TILs are those cells, the tumor infiltrating lymphocytes. Those are lymphocytes that we can find them in the tumor microenvironment. They came there, they infiltrated there in order to kill the cancer, but it did not really manage to, they did not really manage to kill those cells because they're ineffective, maybe anergic, maybe exhausted. And what we do is that we isolate them from those suppressive tumor microenvironment. We expand them in the laboratory, and then we give them back to the patient. So essentially what we do is that we harvest a metastasis from the patient. It's by surgery if the disease is superficially okay, but also if it's in the liver and other areas, we do that. We transfer the metastasis to the lab, and then they grow those cells. It's a rapid expansion. We then before we give those cells to the patients, we give it IV. Before we give it to the patient, we do a preconditioning. We do a lymphodepletion therapy, essentially chemotherapy, quite a strong one. We deplete the lymphocytes of the patients, and then we give the TILs IV, and afterwards we give IL-2, the same IL-2 we inject intralesionally, we give it systemically, and then we just expect the response. We repeat the CT after a month to see what happened there. So we do that from 2005. We achieve a very nice response rate of 29%, and patients achieving a complete response really are alive at many, many years after. I follow patients with complete response who are cured today. It gives me a lot of pleasure to see those patients in the clinic. Today, we combine the TIL therapy with immunotherapy. We give it before the infusion and after the infusion. The microbiome project, it's a very fascinating project that we do here. The connection between the microbiota and the immune system is eagerly studied in various diseases, autoimmune diseases, colitis, and problems like that. But the connection with cancer and immunotherapy is a very recent advancement. Some papers were published, and essentially what we do here in Sheba is that we take the fecal transplantation, essentially the germs from patients who responded outstandingly to immunotherapy, and we transplant those fecal transplant into patients who did not respond good enough to immunotherapy. And then we look at the responses. This is one of the patients we see on the right. The response was impressive, and actually this patient is today cured, and he is a donor today of the transplantation. Today we enroll additional patients to this study, not only melanoma but also MSI high tumors and other indications. So feel free to contact Sheba, this Sheba project. The other project is immuno-apheresis. The rationale behind this method is that the TNF, it's a molecule that we all know for years now. It's a molecule that binds to the TNFR, to the receptor, and it triggers cell death, but the cancer cells have learned to evade the immune system by secreting those TNF receptors into the tumor microenvironment. And what we do here is that we remove those receptors from the blood using a filter. And we do that with apheresis. It's a in the beginning it was a plasma exchange, but today it's a plasma filtration, and we filtrate out those TNFRs. There is some data on this method with dogs and other animals, but we do this in Sheba. We do the first in human investigator-initiated trial. And not only with melanoma patients, we do that with non-small cell lung cancer, renal cell carcinomas, and even triple-negative breast cancer. We started this accrual not long ago, and we are starting to see some results, initial results, obviously. We have a specified facility for this, and a very nice and very professional team. This method is done 3 times a week, not a very simple method. And we do this treatment for 3 months. We combine it in some of the patients, we combine it with immunotherapy. So very interesting and very intriguing, really, trials going on here in Sheba. And that's it for now. I'll be happy to take some questions. So I look at the chat and see the questions. So it's one-time treatment for the immunotherapy and the body. Yes, so there's a very nice question here about immunotherapy and the significance of immunotherapy with melanoma. So every patient is different. Some of the patients really get immunotherapy one time, and sometimes it's enough. We never stop immunotherapy after only one time if we don't have to. But some patients really develop immune-related adverse event, grade 3 or grade 4, which may be even life-risking. And so when the immune-related adverse event is over, sometimes we consider not giving another treatment with immunotherapy. Because we did see a connection between immune-related adverse event and the response to immunotherapy. Those who have an immune adverse events, it means that the immune system has became stronger and attacked not only the melanoma but also the system itself, the body itself. So what I do is that I cure the patient from this adverse event, and then I repeat a PET-CT. And if I see an initial response, I stop. I do not resume immunotherapy. If there's a partial response, we think about it. It's not straight. But the tendency is not to resume immunotherapy, because once the body studies, once the body changes, it changes forever. And we see that with patients who achieve a complete response or even sometimes a partial response after 1 year of treatment, something like that. Some doctors even wait 6 months only after achieving a complete response, and then they stop treatment. They just stop it and not giving it again, and the patient is considered maybe cured. And that's it. I don't see any other questions. I'll be happy to take any other questions if you have any. And if not, thank you very much. And it's been a pleasure.